Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at Keck Graduate Institute, and today we will be discussing advanced cardiovascular life support, or ACLS. The objectives for today's talk will be to list indications for the need of ACLS, to identify causes of cardiopulmonary arrest, to review treatment algorithms for ACLS, and to describe patient care post-ACLS event. Regarding the epidemiology of out-of-hospital and in-hospital cardiac arrest, specifically for out-of-hospital cardiac arrest, or also known as OHCA, about 350,000 cases of non-traumatic OHCA were handled by emergency medical services back in 2015. So there were many cases that were occurring, and that number probably has skyrocketed due to the advent of the COVID pandemic. 10.4% of out-of-hospital cardiac arrest patients survive initial hospitalization, which is not very many, and only about 8.2% of them actually have good functional status when they are discharged. Of those who receive care outside of the hospital for out-of-hospital cardiac arrest, 39.4% actually receive CPR, and only 11.9% actually had an AED or an automated external defibrillator applied by the general public. So it just kind of goes to show you how much knowledge and skill is available out in the general public. Not everyone, as part of their careers, might have training in CPR or basic life support or even ACLS. So whenever we see it in the hospital setting, it's very important that we are able to treat this adequately, quickly, and efficiently, because essentially time matters here. In regards to epidemiology of in-hospital cardiac arrest, or IHCA, about 1 in every 100 patients admitted to a hospital in the United States will suffer an in-hospital cardiac arrest. And only about 26% of those patients are discharged alive, so it's not very many overall. And overall, about 82% of the patients who survive have good functional status at hospital discharge. But it varies depending on the etiology of the cardiac arrest, the care that patients got during that cardiac arrest, as well as how long the patient is down during that cardiac arrest. And the longer that the patient is down, the higher the chance of anoxic brain injury that can occur after the cardiac arrest. And anoxic brain injury just means that the patient did not have enough oxygen supplied to their brain, causing permanent brain damage. And as a result, those patients may not necessarily have good functional status, particularly whenever cardiac arrest events happen for longer than 10 minutes without return of spontaneous circulation, also known as ROSC, R-O-S-C. So what are the reasons why we even perform ACLS or have ACLS algorithms? So we have cardiac arrest rhythms, and then we have non-cardiac arrest rhythms. So the non-cardiac arrest rhythms are probably rhythms that you're pretty familiar with in regards to patient cases. So these are things like bradycardia, and then we also have tachycardia, including wide complex and narrow complex tachycardia. We're probably more familiar with the narrow complex tachycardia because that's traditionally what we see in terms of tachycardia for the most part. Wide complex tachycardia is a little different, as we will discuss. For the non-cardiac arrest rhythms, we're going to focus on bradycardia and wide complex tachycardia for the purposes of today's talk. For cardiac arrest rhythms, we'll actually discuss all of these, and all of these actually have an ACLS algorithm that goes along with them. And those are pulseless ventricular tachycardia, which includes torsade de pointe, which is a polymorphic ventricular tachycardia that you actually see on the right picture here. It's basically a twisting of points. And in addition to the cardiac arrest algorithms that we'll discuss that are in the ACLS guidelines, IV magnesium sulfate should be used to treat this rhythm. Additionally, we'll see ventricular fibrillation, asystole, and pulseless electrical activity. So the first rhythm we'll talk about very briefly is bradycardia. And bradycardia is simply a heart rate less than 60 beats per minute. Many times when a patient is asymptomatic, we don't traditionally always treat bradycardia because there's not really a need to. If a patient has a heart rate in the 40s or 50s, it's sometimes okay as long as they are not symptomatic and as long as they are able to perform their normal activities of daily living. They're usually okay. However, when bradycardia becomes symptomatic, when our patients start to struggle, that's whenever we need to actually treat the bradycardia. And usually, as always, we want to treat the underlying cause first. So say if a patient is on beta blockers and they come in with a type of bradycardia, that's usually an indication that we either need to decrease the beta blocker or discontinue the beta blocker, for example. If the bradycardia persists even after we try to reverse any reversible causes, we can give IV atropine to increase the heart rate. And typically the dosing of this is 0.5 to 1 milligram IV every 3 to 5 minutes, with a maximum total dose of 3 milligrams. If atropine does not work, then you can actually consider our IV adrenergic agonist. So those are basically a lot of our pressor agents that work on the beta-1 receptor. Remember, beta-1 receptor is on the heart. So probably the most strongest and the most common one that is used in this case would be epinephrine, because it does have strong agonism for the beta-1 receptor on the heart. Additionally, other processes that are non-pharmacological can be done for bradycardia in these cases that are refractory to atropine, such as transcutaneous pacing, basically placing pads on the patient to basically pace their heart. In addition, transvenous temporary pacing can also be prepared after transcutaneous pacing is done initially. Another rhythm that we'll talk about that's a non-cardiac arrest rhythm is wide complex tachycardia. And this is tachycardia typically greater than or equal to 150 beats per minute. And depending on if a patient is hemodynamically stable or unstable will basically determine our treatment for wide complex tachycardia. So when we're hemodynamically stable means that the blood pressure is normal. That is our definition for hemodynamically stable. If your patient has a heart rate greater than 150, in that case, we may want to try adenosine first. And what adenosine will do is it will basically slow down that rhythm so that you can actually identify what the underlying rhythm is. 6 milligrams IV times 1 of it is given initially, and if that initial dose is not effective, 12 milligrams IV times 1 or more doses can be tried. With adenosine, it's important to flush all the doses with a lot of normal saline in regards to flush volume, with at least 20 mils being needed, because adenosine has a very, very short half-life. The half-life is typically 10 seconds or less. Therefore, whenever you administer the adenosine to a patient, especially if we're giving adenosine in an arm of a patient, usually what we'll do is we'll try to hold the patient's arm up or at least above where the line of gravity is, so that whenever we are administering the adenosine, we actually administer it properly and quickly into systemic circulation so that it can hit the heart. And remember that the adenosine is only basically being used to break the rhythm apart and basically show what the underlying rhythm is. Sometimes it'll break the rhythm completely. Other times the patient will revert back. And once we have an idea of what that underlying rhythm is, we can actually consider antiarrhythmics such as amiodarone, sotalol, or procainamide. Remember, amiodarone and sotalol are our class 3 antiarrhythmics that are potassium channel blockers primarily. Procainamide is a class 1A antiarrhythmic which works on sodium channels. If the antiarrhythmics are ineffective for a patient that has wide complex tachycardia, then electric cardioversion can be attempted, which is basically another form of a shock. And we'll talk a little bit about defibrillations a little bit later. Defibrillations and cardioversion are a little bit different in regards to the way that they deliver electricity. I just want to make that distinction whenever we say electric cardioversion versus defibrillation. Defibrillation we usually reserve for actual cardiac arrest rhythms many times. And additionally, you may have patients who are hemodynamically unstable, so patients who may have abnormal blood pressure or low blood pressure. And in those cases, we want to usually treat those patients with electric cardioversion for patients who are unstable. In regards to the rest of the algorithms that we are going to review today, they will be concerned with cardiac arrest. So what is the etiology of cardiac arrest? Usually it has either a cardiac origin or a non-cardiac origin. So whenever we think about cardiac origin, the main things that we want to think of are any kind of myocardial infarction that can occur. And whenever you have a myocardial infarction, remember that there is death of basically heart tissue as a result of poor oxygen delivery through the coronary arteries for many different reasons, the primary one being atherosclerosis of the coronary arteries, which will result in plaque formation and basically a clogging up of those coronary arteries to where oxygen cannot be properly delivered. So as a result, we may get ischemia of the heart, a deadening of the heart tissue, and depending on the extent of it, sometimes it will actually stop the heart from pumping and doing its job. Additionally, we may have electrical or action potential disturbances that happen within the heart. So a lot of these things we typically think about are arrhythmias. And whenever we cannot properly deliver electrical impulses throughout the heart because of a deadening of tissue or because of other reasons, that basically can result in cardiac arrest. And there's obviously many others that we also need to consider also. One of them being heart failure. If you have a patient with heart failure, that can eventually lead to respiratory failure, for example, which is a non-cardiac origin of cardiac arrest. And the way that heart failure does that is if you are fluid accumulating so much and you don't get enough oxygen delivery to the body because you have so much fluid in your lungs, that can result in respiratory failure. So that's the first cause of cardiac arrest without cardiac origin, is respiratory failure, so hypoxia. Toxic ingestion of many different substances. One of the most common ones, as we see on the right side of the slide, is opioids. Opioid epidemic and pandemic really, has been very detrimental in terms of the morbidity and mortality that it has caused. And the way that opioids do that is just from more or less respiratory failure. We also have patients that can develop pulmonary embolisms that can cardiac arrest. If that pulmonary embolism is of significant size, such as a subacute or a massive PE. Additionally, drowning. So drowning kind of goes along the lines of hypoxia, where basically a patient might have water basically filling their lungs because of an accidental or purposeful drowning. Sepsis and septic shock is another big one. That can basically result in respiratory failure or acidosis, which can cause cardiac arrest. DKA can cause acidosis, causing cardiac arrest. Trauma is another big one. That can actually, result in blood loss, volume loss. It can also result in organ damage, such as pneumothorax, where you have a collapsed lung. And as we'll see on the next slide, collapsed lung is a cause of cardiac arrest also. Patients also may become dehydrated or hypovolemic. So we not only think about dehydration in terms of basically us sweating off fluid or getting regular volume removed. We might also get volume removed in other ways. Patients might be on dialysis where they get a large amount of volume taken out over a small portion of time, and that can cause problems, particularly in dialysis patients. If the fluid is taken off too quickly, they can cardiac arrest from that. And there are many different other things that can contribute to a cardiac arrest. It is not just the ones that are limited on this slide, but I do want you to keep in mind a lot of these common causes, because they will actually lead into our more solidified or concrete causes going on to the next slide. In terms of simplified etiology of cardiac arrest, we commonly think of the different causes of cardiac arrest to be known as the H's and T's. So these are basically the simplified reasons of why someone would cardiac arrest, and these are very important to know, hint, hint, star, star. So some of those, as we kind of alluded to on the last slide, include hypovolemia, hypoxia, hydrogen ions or acidosis, hypokalemia or hyperkalemia, and hypothermia, or basically being cold. Additionally, for T's, we have tension pneumothorax, which is collapsed lung, cardiac tamponade, which is basically a collection of fluid between the different layers of the heart, which actually may cause the heart not to be able to pump properly, because it needs a certain amount of elasticity to be able to stretch out and basically pump properly. So if basically a patient's heart is filled between the layers with fluid for a variety of reasons, that might be a reason for a patient to cardiac arrest because of cardiac tamponade. Again, we mentioned toxins and toxic substances on the last slide. That applies to T here. Pulmonary thrombosis is another name for pulmonary embolism here. And coronary thrombosis is another name for myocardial infarction. So these are basically the H's and T's that can result in a patient developing cardiac arrest. And a lot of these, as you saw, are related to the regular etiologies that we saw on the last slide. So whenever you think about what is causing a cardiac arrest, you always want to think about these things in regards to the etiology and in regards to whatever you want to try to reverse in terms of the reversible causes. So whenever you are doing your ACLS algorithms, and the algorithm will say, think about treating underlying causes, these are the things that we want to potentially treat. For hypovolemia, obviously that would be volume. For hypoxia, that would be oxygen. For hydrogen ion slash acidosis, we give patients bicarb. For hypokalemia, we can potentially supplement them with potassium slowly if it is hypokalemia, and we can potentially give them calcium in the form of calcium chloride in the code carts, or bicarb, sodium bicarb. For hypothermia, we can attempt to warm the patient. For tension pneumothorax, we typically place chest tubes for those patients. For cardiac tamponade, a process called a cardiac window or a pericardial window may be done to basically remove fluid from between the layers of the heart. For toxins, it's basically your fundamental poison management. For pulmonary embolism, if it is a massive pulmonary embolism, TPA or alteplase can actually be considered to be given as an infusion of 50 milligrams per hour over 2 hours for massive PEs. And for myocardial infarction, the patient, after they arrest and hopefully they make it, can actually be taken to the cath lab for a percutaneous coronary intervention to basically evaluate the coronary arteries to see if there is anything there that needs to be addressed so that the event does not happen again. So those kind of simplify basically treating the underlying causes. And even though they are mentioned specifically as things to look out for in the ACLS algorithms, they're not always specifically addressed within the algorithm itself. The algorithm mainly focuses on whatever rhythm you see and what you need to basically do about that said rhythm. So this slide here just kind of outlines the basic chain of survival in regards to in-hospital cardiac arrest and out-of-hospital cardiac arrest. Whenever you're in hospital, as you see on the top, you're basically trying to recognize and prevent in-hospital cardiac arrest when possible. You always want to activate the emergency response system, provide high-quality CPR, defibrillation when needed, and hopefully once you get the patient back, post-cardiac arrest care and recovery. For out of hospital, it's always important whenever you see someone who is unresponsive and does not have a pulse, or is not able to basically respond to you, to activate the emergency response system immediately. You need to basically get help to wherever you are at first, before actually performing CPR, because if you don't have the resources there, you may not be able to do it on your own if you are basically out in the field, as they would say. Additionally, you have CPR, defibrillation, advanced resuscitation, which can happen in EMS or at a hospital, post-cardiac arrest care, and again, recovery. So components of ACLS, particularly for cardiac arrest. We basically want to talk compressions, breaths, medication, and defibrillation. And whenever you went through basic life support training, you were probably very familiar with the compressions and breaths and introduced to defibrillation through the advent of AEDs, or automated electrical defibrillators. The one thing that we're going to add to what you already know is basically the medications and where the medications actually fall into this. So how do we go about administering the medications? So if you have a patient in the hospital who is cardiac arresting, you want to basically make sure that you have IV access for that patient. Most patients in the hospital will not have a central line unless you're already in the intensive care unit. And remember, cardiac arrest can happen anywhere in the hospital. So if we have a central line already, great. If we don't have a central line, we at least need to put a peripheral line in. Central lines take some time to put in because it is technically a surgical procedure. This procedure can be done at bedside. However, it does take a little bit of time. And whenever you are having a patient with cardiac arrest, time is basically tissue, and in this case, it's brain tissue. So a lot of times, it's going to be okay to place a peripheral line in. And a lot of times, a peripheral line will be able to be obtained if one is not already there. Most of the time in the hospital, a lot of patients will typically have at least a minimum peripheral line, either a left or a right peripheral line, to basically give them medications via. But central line access is generally preferred because, remember, central lines typically will terminate in the superior vena cava, which is basically at the right atrial junction of the heart, where the right atrium is. And whenever you give medications in that area, they are basically already at the heart. If you have to give medications peripherally, it will take some time to get to the heart. And the heart is basically what we're trying to jumpstart in this process of cardiac arrest. If for some reason you cannot obtain an IV access for your patient, either peripheral or if it's going to take some time to get a central line, you can actually install an intraosseous access or intraosseous administration second line. And that's actually what you see here, which is basically, another form of access where we actually can insert a needle into a bone such as the tibia of the leg. And at that point, we can actually start administering medications that way. Medications that are administered intraosseous basically have 100% bioavailability, just as IV medications do. So you have basically the same dosing that you would get from an IV administration of these meds. The last line is endotracheal route. An endotracheal route, as we know, is basically the endotracheal tube that is used traditionally for intubation, if we have access to that. It's usually used last line, and it's not very common. However, it does have some special things that you need to keep in mind. With endotracheal tube medication administration, as we said, it's last line. But there are only certain medications we can administer that have data behind them for endotracheal tube medication administration. And we think of those as naval. Those medications are naloxone, atropine, vasopressin, epinephrine, and lidocaine. Make sure not to get atropine mixed up with amiodarone. These 5 medications can be administered via an endotracheal tube, as you see on the right side here. And typically the dosing is going to be much higher than what we would give for IV administration. It might be 2 to 2.5 times the amount given for IV to IO. Now, in terms of dosing, and I'm going to kind of, say this as a blanket part on this PowerPoint, there will only be certain medications that we'll talk about in class that I want you to know the dosing of. I just want you to have a general idea for the endotracheal tube administration that most of the time the dosing is not 1-to-1. That is the main thing that I want you to get off of this slide, in addition to the medications that can be administered via endotracheal tube, hint, star. Compressions and breaths. These are probably things you're very well aware of from basic life support. So obviously, whenever we have a patient who's unresponsive, we want to activate the emergency response system first once no responsiveness is verified. You don't even necessarily need to check a pulse because it's going to just waste time. You need to basically see if the patient is responsive and then just start CPR. And usually for adults, we do 30 compressions for every 2 breaths. The compression rate needs to be at least 100 compressions per minute. A lot of people will typically think about the song Staying Alive whenever they are doing chest compressions so that they can get the adequate amount of compressions per minute. It has to be at least 100. The compression depth needs to be at least 2 inches down, also known as 5 centimeters if you're using the metric system. And if you have another person nearby you, whether you are out of hospital cardiac arrest or whether you're in hospital cardiac arrest, if you have someone else that's nearby, it's going to be helpful to alternate chest compressors at least every 2 minutes or 5 cycles so that you can basically be able to rest and then basically gain a little bit more energy back so that you can potentially do it again if the cardiac arrest continues. So these are basically the big components of BLS, or basic life support, which you have been certified in the past. And this is basically the basic life support algorithm. I'm going to refer to the ACLS guideline document that you have in your learning module system throughout. So please, whenever you are referring to these slides, pull up the actual PDF. The PDF will be testable for test purposes for each of these. We're not going to necessarily go over each of these algorithms right now in this pre-class PowerPoint, but we will go over them more in detail in class. This is basically just a lot of the things that we have already addressed, more or less, kind of in the last few slides in regards to verifying for responsiveness, check to see if the patient is breathing, and then you can check for a pulse and see if you have a pulse or not, and then start CPR. Furthermore, past BLS, we actually have an adult cardiac arrest algorithm, and this is in page 9 of the ACLS guideline document on your learning module system. Depending on the EKG rhythm during the rhythm check, as you'll see here, and this is steps that we're going to go through in class, medications and defibrillations may be administered per this algorithm. So this algorithm will be basically keystone for you to understand for your final exam, hint, star. Defibrillations are only administered to patients with the following rhythms, and that's pulseless ventricular tachycardia pulseless ventricular tachycardia and ventricular fibrillation only. We do not administer shocks to patients with asystole or pulseless electrical activity. And we may consider other interventions in addition to ACLS to treat underlying causes that we mentioned before, which are known as the H's and T's. So we're actually going to go over this algorithm and walk through this algorithm in class so that you are able to understand what exactly is going on and basically what are the different steps of the process, because it is something that is much easier done than said. This is, again, the algorithm, but I just wanted to highlight what the different rhythms look like. And for the exam purposes, I'm not going to have you necessarily know what the different rhythms look like for the exam. I'll tell you what the rhythm is, and then you'll basically be responsible for telling me what to do about it. So in this case, the top rhythm you see here is ventricular fibrillation. The second rhythm you see here is a monomorphic ventricular tachycardia. Monomorphic means that it's very symmetrical in terms of the twisting that you see here versus the polymorphic that we saw with torsades earlier that was a little bit more random. The next one is asystole, which is basically what we consider to be flatline. This is the one that you're probably most familiar with whenever you're thinking about like television and whatnot. And then the bottom one, actually looks like a normal rhythm, but if you have no pulse and your rhythm is not one of the above three, then at that time, you're basically just considered pulseless electrical activity. So if you don't have a pulse and you are not one of the above three rhythms, asystole, pulseless ventricular tachycardia, or ventricular fibrillation, you are PEA, or pulseless electrical activity. That is basically an electrical activity that is occurring where you don't have a pulse necessarily. Additionally, there is this circular algorithm that is very useful, that is on page 10 of the ACLS guideline document. That we will refer to whenever we are in class, and it will give you basically the dosing of some of these agents also, such as epinephrine and amiodarone. And for exam purposes, those are two of the doses that I do want you to know, which are epinephrine and amiodarone, as they are two of the most common medications that are administered during ACLS. Epinephrine is typically given 1 milligram every 3 to 5 minutes. This can also be known as basically 1 milligram every 2 pulse checks, 2 pulse/rhythm checks. Additionally, amiodarone is typically given 300 milligrams bolus IV times 1 for the first dose in the ACLS algorithm, and the second dose is 150. This is just a larger version of the circular algorithm, so you can see it a little better. But it is in the ACLS guideline document. So of the components that we talked about, which ones actually help patients? Ideally, we want everything to help a patient, but there are some things that we do that may or may not help. Compressions and breaths that are associated with CPR are things that have been shown that help patients survive. Additionally, whenever you can defibrillate a patient, such as patients that have pulseless ventricular tachycardia or ventricular fibrillation, those are the patients that a lot of times will tend to do better, because those are patients that are able to be shocked. And those are a lot of times the patients that have better outcomes. If you have a patient that has asystole or PEA, we're not able to shock them, and as a result, the outcomes are not as great, even though we're giving compressions and breaths. If you have a baseline asystole or PEA, the outcome is not going to be as good. Additionally, medications overall for ACLS are not always going to be helpful. There is data suggesting now that epinephrine can help in the ACLS algorithm. However, no other drug has really kind of basically met that match in terms of epinephrine. They used to actually incorporate vasopressin into the ACLS algorithm. However, that is not standard practice anymore for one of the first 2 doses of epinephrine. And that's basically just because it had no extra benefit in regards to mortality benefit. And whenever we think about vasopressin versus epinephrine, vasopressin is actually very, very expensive compared to epinephrine. So therefore, we want to basically make the best use of our resources in terms of not only just efficiency, morbidity, mortality, but also cost savings. So in general, what I want you to get from this slide is, yes, epinephrine can help in terms of medications, but generally, the medications are not helpful unless you're actually targeting an underlying cause. So usually what we think about are compressions, breaths, and defibrillation being basically the gold standards when we can defibrillate. Because remember, we can't always defibrillate, especially if we have pulseless electrical activity, PEA, or asystole. Medications are great, but in ACLS, they're not as great. Delivering high quality CPR and defibrillating a patient, it has a lot of good data in regards to saving patients. Epinephrine has some, but generally, even though we give the medications, it's basically not always something necessarily to just make ourselves happy, because sometimes the medications do save patients, but there's just conflicting data on this. Whenever you have a patient who eventually survives cardiac arrest, and basically what we have as ROSC obtained, return of spontaneous circulation, we want to do the steps that are in page 56 of the ACLS guideline document. So we want to manage the airway. We want to basically maintain appropriate respiratory and hemodynamic parameters. And then we also may consider underlying causes. So patients who have STEMIs present or ST elevation MI might need to go to the cath lab, for example. We might need to manage cardiogenic shock. We may need to put a patient on mechanical circulatory support like ECMO, or a ventricular assist device like we would see in patients with heart failure. Additionally, we have to evaluate patients also depending on if they are actually awake and alert, or at least awake at minimum, or comatose. And that will sometimes dictate what we do in regards to the patient next. This is just a larger version of the post-cardiac arrest algorithm here. One thing that we might do for patients is known as targeted temperature management. And this may be completed in patients post-cardiac arrest who are comatose. So we don't traditionally do this in patients who are awake after they have cardiac arrest. So what will happen is patient will obtain return of spontaneous circulation. So basically they've been revived successfully or resuscitated successfully. And they are alive, but they may be comatose. In that case, we can potentially do something known as targeted temperature management. And it used to actually be known as therapeutic hypothermia. However, the term for it changed because in some cases, we're not always going to make the patient hypothermic or cold. We may just make the patient a little bit, lower than what their normal temperature is, or close to it. Typically for these patients, what we want to do is we want to actually lower the temperature of their body down to between 32 to 36 degrees Celsius for at least 24 hours, and typically no longer than 48 hours. The reason why we do this is basically to try to preserve neurological function. There are many different mechanisms of how this is actually happening, and it's not completely well understood, nor is targeted temperature management, fully accepted in practice. There used to be data that suggested that if a patient had only a witnessed arrest, that targeted temperature management should be done. If it was an out-of-hospital arrest or an unwitnessed arrest, as they would say, targeted temperature management was said not to be done previously because it didn't necessarily improve outcomes. Now, technically, the recommendations per the 2020 ACLS guidelines say that you can do it in any patient who is comatose after a cardiac arrest. Now, whenever we're trying to basically make a patient colder to try to maintain their neurological function, because that's basically what we're concerned about post-cardiac arrest, we may consider different medications. We might consider antipyretics, such as acetaminophen. We might consider other medications like Buspar or buspirone, magnesium sulfate. We might consider sedation. We even may, at the deepest level or the most furthest level down, last line, basically consider continuous paralysis for these patients. So we may actually put a patient on a cisatracurium, vecuronium, rocuronium, IV continuous infusion to minimize shivering for these patients. Because remember, our goal is to keep them at that low temperature of 32 to 36 degrees Celsius. Whenever your body goes that low in terms of temperature, your body's natural response is to want to shiver. And for what we are trying to accomplish here, we don't want them to shiver. We want them to stay at that low body temperature. This temperature is actually maintained by different machinery. One piece of machinery you see here is actually connected to patients, where you can actually adjust the temperature over time. Sometimes these machines are directly connected to fluid circuits or other type of circuitry that basically can cover the patient to more or less lower the temperature and raise the temperature as appropriate. Generally, fluid boluses or of cold fluids are not recommended anymore for hypothermia because of the excess pulmonary edema that may result from patients getting this excess fluid. So I just want you to be familiar with what this process is, why we're doing it, to basically preserve neurological function, the patients that it can be done in, and the medications that can be considered whenever you have a patient with targeted temperature management in regards to minimizing shivering, because that's usually the big role that we'll play in regards to being pharmacist. So what happens if you have little or no response after your cardiac arrest? So, you go through this targeted temperature management, you basically wait a few days, you get a neuro evaluation, from a neurologist, utilizing many different assessment methods and diagnostics, including an EEG, an electroencephalogram, and the neurologist physical assessment. What happens if you have permanent anoxic brain injury? Sometimes it may be minimal, and sometimes it may be completely paralyzing, where patients are not actually able to function. Sometimes some patients that have a GCS greater than 3 may be placed in a long-term care facility. Sometimes they even get placed there with a GCS of 3, which is very sad, but it is something that is considered. Additionally, family or, caregivers or friends or whoever is basically the patient's next of kin have to decide if they are going to have to place the patient on comfort care or end-of-life care, because the actual recovery rate is not that high. And in this case, what happens is all life-saving interventions are basically discontinued. So that includes like mechanical ventilation, vasopressor therapy if they're on that, dialysis, etc. Usually at this point, the patient is, actively dying because they are already on life support. Usually what we'll do for the patient is we'll basically make them comfortable. We're going to start usually a morphine IV continuous infusion for the patient to relieve any kind of pain and suffering that the patient has. And usually that morphine infusion will be titrated up. Patients have a morphine allergy for some reason. Fentanyl technically can be used because it is from a medchem perspective in a different medchem class than morphine itself. So that is something that can be considered. But we're basically going to make the patient comfortable in any way possible as they're actively dying. And sometimes this process might take just a few minutes or a few seconds after they have their life-sustaining devices like mechanical ventilation turned off. Sometimes it may take a few minutes, a few hours. Sometimes it may even take days. Sometimes patients even come back, completely. That's not as common, but sometimes it does take a while for nature to take its course. And during that time, we want to make sure that the patient is completely comfortable. We may consider medications to reduce secretions like glycopyrrolate or scopolamine patches, and additionally sedatives to make sure that patients can sleep appropriately and be able to relax and have, an adequate end of their life that is not pained and really more or less suffering. We want to try to basically maximize the patient's life wherever possible. These are the references for today's talk. And if you have any questions regarding ACLS, please feel free to contact me. Thank you and have a great day.